It's been requested that I talk about non-surgical rhinoplasties. Non-surgical rhinoplasty or liquid rhinoplasty, what it's referring to, well, it can now refer to like threads and weird things like that, but classically it's just referring to fillers that you use in the nose to change the accent and the shape of the nose. You can also use Botox in the nose. When you're looking at rhinoplasty, you've got surgical, non-surgical. Surgical means you're actually doing a surgery, which you can actually change the shape of the overall nose, the height of the nose, the projection of the tip. All that is surgical. Non-surgical, you can play with camouflaging things by adding soft tissue volume. So you're adding soft tissue volume to diminish shadows or to build up a radix and make a bump look smaller or move the tip around. And then you can use Botox as well. So that kind of stuff, you can use temporary or permanent fillers. I highly advise using temporary fillers, meaning hyaluronic acids, because they're going to be a lot safer in case anything ever happens, and things can happen. Risks are pretty low when it's done with somebody who's really, really good. The risks that we're worried about, the one that people freak out about when you talk about it, is blindness. And the risk of blindness in the nose itself in this area is actually pretty low. The areas that we worry about are once you get out to the side of the nose or up in the glabella. The glabella has two kind of vessels which can be circuitous, meaning they go out in different directions and loop around, and they're not in places that you would normally expect. So definitely those areas are slightly riskier, but still I would say that the risk of blindness when done by somebody really, really good is almost zero. Nothing's zero, but it's almost zero. And the risk of blindness with doing injections in the forehead or the under eyes would be kind of about the same. So those are your kind of like big risks that people worry about. The risk that's most common that happens is that people can get areas of poor blood perfusion. So the skin, you can either inject into a vessel or next to a vessel that is adherent, and it compresses that vessel. This is much more common in revision rhinoplasty. So if somebody's already had surgery before, they can have areas, especially in this region, it's very common, where it can be kind of matted and stuck down, and you do an injection next to it and just compresses that vessel and you get a blush in that area. The skin can turn just kind of mottled and blotchy, or it can actually become dark and black and then die off. That's uncommon. If that does happen, it's uncommon, but it's still possible. And if that happens, you have to hit vitreous, which is a dissolver, or hyaluronidase in the area to dissolve the filler, and then you send the patient typically to do hyperbaric oxygen treatments, or you can put a leech on it. You can do a million things that people do. Hyaluronidase, and then there's other kind of consortium, not studies, but publications that tell you to do everything under the sun to improve the wellness of the skin afterwards, to prevent inflammatory problems, telangiectasias, and things like that can occur. When we're looking at the filler type, you have to be aware that the fillers themselves can have long-term side effects. So aside from the short-term side effects that we worry about, where you get vascular occlusion or things like that, you can have long-term side effects. Vascular occlusion can have long-term side effects. Vascular occlusion itself, when it happens, the area will get blanched first, and then it starts to get poor perfusion, and then it goes dark. So it doesn't go dark right away usually, and you can get venous congestion or arterial either way. If that happens, you can expect that in the next day you'll get some redness in the area, and the following day you'll start to get vesicle formation. And the vesicle formation is kind of a delayed sign of either skin breakdown, where you get vesicles forming just because of the layers losing their strength, or it can actually just happen as a reperfusion, oxygen-like reperfusion reaction. That's a big area of confusion for people. They think that when they see the vesicles and they see that the patient's getting an infection or they have an allergy. It's neither. It's actually an expected sequelae or an expected kind of consequence of getting the area reperfused or just being ischemic in general, having a poor blood supply. Those are patients where, I'd say hyperbaric would probably help the tissue quality in the long run, because you can revascularize faster, or by doing a leech treatment. So you could actually put a leech on it over there, and it would help kind of decrease the inflammatory response in the area and increase perfusion. Long-term effects of these fillers, there are a lot. So you have to be very, very aware of what fillers can do in the nose. Fillers, when we place them in the nose, If you're using a hyaluronic acid filler, if it's something like Restylane Lift, Voluma, those things tend to be less hydrophilic, hydroscopic. They don't bring in as much water. And that means that they kind of sit there and the skin quality itself stays almost the same. If you use something like Juvederm and you use Juvederm up in this region in the glabella, for example, Juvederm will tend to draw in water over time. So it is an area where we largely recommend not using Juvederm for the glabella or anywhere in the nose. It's not a good injection for the nose at all. Over time, it can draw in water, and injections like hyaluronic acid, like Juvederm, they don't last 6 months and they're gone. These things can be permanent. They can last 10 years, 15 years. You never assume that a temporary filler is temporary because they may just stay there and accumulate residue and kind of stay for years. The changes it can make up there is just getting thicker and wider, but let's say you have it in the tip and you use it to push the tip up. If you put too much, you can actually broaden the cartilages, split what we call the cleft in between the lower lateral cartilages and the domes, and make the nose wider over time, and you can actually slowly lose strength of the nose as it expands it downwards. So those are risks to having it done poorly or having too much placed or too much in the wrong area. So these things can all happen. Permanent fillers can be much more destructive. So Radiesse is a calcium hydroxyapatite, not something you ever want to inject in the nose. Radiesse, it's a bony paste, and when it's injected into the nose, it can cause small calcifications and bumps and things like that. More than anything, if you have Radiesse in the nose and you accidentally inject it into a vessel, now you get an occlusion that you can do nothing about. You can't fix it. You can't get rid of it, and you have a much bigger problem. And you don't get much of a benefit of using Radiesse anyways compared to the longer lasting hyaluronic acids. Beyond that, you have silicone and silicone-like polymers, which kind of group into that silicone, which is like you can have industrial silicone where they get it from Home Depot, or you can have the fancy S1000, which is more of an oily, thin substance. Still, those are very reactive materials and can cause problems over time. There are some doctors who do it and don't have many problems. I would never take that risk myself, but I would never say anything bad about a couple of doctors who do it and do it well. Still, if you're related to me and my family, you're not getting that done ever. Beyond that, you have Bellafill, Artifil, Articol. There's different ones that fall into that category. Again, I would not use those. When things go wrong, they go wrong badly, and you don't know if something bad's going to go wrong now or 5 to 10 years from now. It becomes difficult to fix. And this is different than silicone implants. These are silicone injections. Fat is kind of in this middle ground where it doesn't carry as much risk as silicone, but it's not as benign as hyaluronic acid. So I caution people putting fat in the nose, a place where people have gotten away with just doing small droplets or for little tiny defects on the side over here on the top. And if you're with a good doctor, they can certainly do that. However, most areas in the nose don't really respond well to that. Then we get into threads. Threads, I think, in the nose are not a good idea. I don't know any rhinoplasty surgeon who's a good rhinoplasty surgeon who supports them. I do know several respected doctors who are not rhinoplasty surgeons who say they get great results with them, but I am really not convinced. So I think the downsides of threads for the nose are much, much higher than any positive you could say, and the results are likely short-lasting if they're good. If they're long-lasting, I really don't know what to think of it. So personally, I don't like threads, and I can't foresee anything or any scenario where actually threads would be good, but there are some doctors who I like who use it, so I don't have anything more to say about that. The Botox, you can go nuts if you want. It's really not too harmful, and people place Botox for the smiling depressor, the nasal depressor muscle that pulls your tip down. Some people do it because they have a bunny rabbit type nose like that and you can Botox. Others do it because they flare their nostrils too much. If you do it to somebody who's flaring their nostrils because they're compensating for poor airflow, then you're going to make their airflow slightly worse when they exercise. So just something to be aware of. And you can use Botox, Dysport, Xeomin, Juvo. It does not matter. Down here, you usually use about like 5 units on the depressor, on the nasal spine, into the columella. If you ever try to detach behind the muscles that are just behind the tip, you can use maybe like 6 units, and then across the whole thing, maybe 10 if you're trying to do all the flaring stuff. Back to how to do it. There are patients who just should not get it. There are patients who either are more like lend themselves more to getting a rhinoplasty because they need bigger changes, or because they're gonna get a rhinoplasty in a year. If somebody's getting a rhinoplasty in a year, don't inject them. Don't subject them to that tiny little risk, and also don't make it harder for the rhinoplasty surgeon to give them a lifelong better result. I would say you really have to just kind of time it appropriately, where if you're ever gonna do it, make sure they're very far away from surgery. Otherwise, it's annoying to go to try to dissolve it and you miss something and you don't know it's there and you can't correct for it during a surgery. When you do it, be minimalistic. It's a beautiful thing to do. I used to do tons of cases. I don't inject much anymore now, but I was doing minimum one a day. I was doing probably like 1 to 3 cases a day where I was injecting noses. And my style was just very subtle, delicate. And that's how I tell other people to do it as well. And I'll show you. So this is on my website, and these are cases where I'll show you the simplest one. This is by no means impressive, but it's a patient where I added a little bit to the radix over here and then a tiny bit to the tip over there. So it just helps build that up over here to make the bump look smaller, and then the tip comes forward, and you can see it gave a nice little change in character for her. And that for me is a nice little successful thing. No problems, no issues. If we look at other ones, same kind of idea. You'll see that the bump is there, bump is not. That's just from putting the tiniest bit over there, putting the tiniest bit of Botox there, and then a touch of filler at the tip. If you're asking about using Volbella under the eyes, I'm completely against that, but people do it and get away with it sometimes. Here's another one where you can see this is a nice case where you're not getting rid of somebody's bump. You're diminishing the height of it by bringing up the valley. So it's a mountain and a valley, and you bring that up. But if you just did that, the nose would have a continuous down-pointed appearance. The way you compensate for that is by putting the tiniest bit in the tip over there, and that allows it to maintain a little bit of its projection. So everything is relative. So the tip has to stay projected relative to the dorsum, and then dorsum usually has to be small relative to the radix. Radix has to be deep relative to the forehead. So you're just comparing relatively every part of this profile. If we were to have taken the radix and built it up higher, that would have made the forehead to the radix look blunted, so it looked like a Trojan helmet appearance, and then you'd get, again, more of a down point as you come down to the tip. So she's somebody where you look at it and stylistically you say, you know what, I'm just going to do a dot there, and call it a day. I'm not going to try to get rid of that entire bump. And typically what I do is I inject them, and then I have them come back 3 weeks later, and I inject them again. So I never over-inject. So let's say you do this guy, and you tell him, hey, listen, 10% of this is going to go away. 30% of this is going to go away. Whatever you think your number is. I don't tell them that. I say, I'm going to inject it to how it should be. I'm not going to overcompensate. Come back in 3 weeks. I might need to touch it up. And all I do is see him 3 weeks later. I hit it. And then usually it'll last 9 months to a year after I do that. Cases like this are pretty straightforward. You see the tip looks like it's kind of drooping, a big hump on the top. Again, her big limitation is she has a shallow forehead. Shallow forehead going into a not so deep radix. If you build that up, again, you end up with this nose that starts on the forehead. You don't want a nose that starts on the forehead. You want to have a subunit separation called the radix, which is the root of the nose. You want it to start a little bit deeper. So I brought her up only to where I was able to, and then again brought the tip forward a little bit to relatively keep the tip projected compared to the rest. I go over a million of these, but you'll kind of get the idea. Here's my friend. So this man is somebody I used to water ski with all the time. He's a wild person. You can see his tip was tautic and drooping, and he had just a little bump there. He's not somebody you want to go this far on, but since he's my friend, I said, you know what, I'll go for it. So I projected his tip slightly with filler, probably more than I would use now. So this is a case where I'd say if I were doing this now, I would not have placed so much to make that happen, just because I'm worried about the long-term issues with it. But on him, he did perfectly well with it, and he was happy with it last time I saw him. This is another one of my friends. Little tiny bump, little drooping on the tip. Again, you can't do much with this nose. So I camouflaged by putting a dot above, a dot below the bump, and then a dot on the tip. So the idea is to bring up these two areas slightly to make the bump look less. During a surgical rhinoplasty, you'd be shaving that down to take it down. These areas, when you're injecting down pretty much onto the bone or onto the periosteum. The risk when you're injecting somebody in the midline is very, very low. When you're in the midline, there are not many vessels that would come out of the midline. That would be a risk. So in the midline, you're really only worried about over-injecting, or you're worried about revision cases if they have adherent skin and it's stuck down. Otherwise, in the midline, you're not worried too much. So the risk really comes not when you're directly paramedian, but when you go lateral. So when people inject out here, that's where you get risky. That's where you have those larger caliber vessels as they go from lateral to medial. So those are a little bit riskier over there, more risky in patients who've had rhinoplasty before. So when injecting, I stay pretty much midline or directly paramedian, and that's where most people stay. The big mistake people make is if a nostril is retracted or high, and they try to put a filler in there as a spacer to push this down. In their mind, trying to replicate rhinoplasty, meaning the rhinoplasty, imagine you go put a cartilaginous spacer, cartilage, or soft tissue, or a composite, and that brings it down by pushing the border of the nostril down. Fillers can't do that. So this is a super, super risky area to ever put a filler. It can really only cause problems. There are exceptions where we're talking, okay, in the soft tissue triangle, there's a tiny indent from atrophy and you try to microneedle some hyaluronic acid, but otherwise, it's a very risky thing to do. So I'd say stay away from injecting everything on these areas. But a patient comes in and says, but listen, I don't want to get a surgery. I just want this. And this other doctor did it for me once. It doesn't matter. That doctor got away with it. I'm not going to risk it. So I have to tell patients that all the time. Even if they got away with it, I'm not going to risk it. But they said, but it wasn't a problem. And so I have to give them a quick analogy. I say, listen, it's kind of like crossing the freeway. Maybe you ran across the 405 in the middle of the day and nobody hit you and you got lucky. It doesn't mean that every single time you're going to run across the 405, nobody's going to hit you. Most likely, actually, 9 times out of 10, you're going to get hit or almost hit or cause another issue. So that's something we have to remember. It's just because it didn't happen once, it has zero reflection on what's going to happen in the future to somebody. So you have to be very, very cautious injecting the wrong places. Some things you cannot do with non-surgical rhinoplasty, and that's why I like to show kind of, these results, is because you see the range or variety of what can be done with a rhinoplasty with just injections. Okay, so you can see this does not look like a non-surgical, but it's non-surgical where the tip was brought forward a tiny, tiny little bit and the hump was reduced by building up above the hump, meaning the radix, so the root of the nose. So, you see lots of similar results, little bumps, little tip projection. This is a nice one. Just somebody with a very elegant, delicate nose to begin with. Doesn't need anything. And I think I even told her before, you really don't need this, but she just wanted to have a little bit of improvement on that bump. So we do just a touch of Restylane Lift is what I use. I usually use Restylane Lift. Voluma is a great one too. The other doctor who's amazing at this and does a lot is Dr. Rivkin. He uses Voluma mainly because it has a nice long duration to it and it's a nice flexible gel that's easy to inject. Here you can see another nose that has a general kind of down point to it and kind of a bump and a bump. So that's the top of the lower lateral cartilages. We camouflage by putting a tiny, tiny bit of filler there and a tiny bit on top, and that's it. And this is a very close family friend. So big hump, down point, little projection. And this was in my old office. You can see the green in the back. That's my old office. So that was 4 years ago. And this lasted 4 years. So, some of these patients, they last 1 year. Some of them, they last 9 months, and then you inject them again. And then they all of a sudden, and not all of a sudden, but they last 5 years, 6 years, 7 years afterwards. I never tell patients it's going to last that long, but it certainly does. And it's important to know that because you don't want them coming back and saying, well, I checked the last time I was here, it was September, so now I feel like I should be back. Fillers do not go based upon a calendar. They don't go away at 9 months. They don't go away at 6 months. They go away whenever they want to go away, or they never go away. These fillers are little tiny gel beads that are in your body, and sometimes it's where they naturally don't exist, the hyaluronic acid, so your body might keep it for longer. So it's important to know that when you're doing under eye fillers, cheek fillers, nose fillers, lip fillers, these things don't go based on a calendar. They don't stay there for 6 months and then you have to re-up. You don't have to re-up, and it's better not to. You want to have as little volume from this stuff in your face as possible that's going to draw in water. You want a face that has nice kind of delicate architecture and really has kind of nice definition around the face and not just one big kind of blob of water. So injection rhinoplasty, where the patient comes back 6 months later and says, hey, I want to do it again just because it's 6 months. You say, no, it looks perfect. Come back in another 6 months or a year or whenever you want. The Botox stuff in the nose doesn't seem to last as long. Probably it does last about like 5 months, maybe 6, and you can repeat it as needed. I don't see many bad side effects from it, except for when people go a little bit too low, then they can drop the smile. So you have to be cautious of that. So I think that's it for the minor lesson in injectable rhinoplasty, but I hope you understand the limits of it as a patient or a doctor and why to do it, when to do it, how frequently to do it. And definitely, again, you're not using anything up there that's going to be permanent or Juvederm or anything like that. The worst is silicone. It's really, really bad when it goes up there. So that's all. We're going to post this later. And if you have any questions, you can always contact us on the Instagram or the office.